G'day. Welcome back to another episode of the Sports Medicine Project. Very big milestone, episode 50, the big 50. It is. Woo. Do you even check anything with our podcast? You just come in here and record and then just leave me to be. Yeah. That's all right. You've got the knowledge, so it's okay. So, I'm Blake. If you're listening to this, a bit loud, is it? Yeah, if you're listening to this for the very first time, I'm Blake. Welcome to my co-host, Kelly. How you going?
I'm good. How are you?
Yeah, I'm good. How was your week?
My week's been good. I can't think of any lows of the week. I'm struggling to think of any lows.
It's always a good week if that's the case.
You know what started this as being a good week? Was how good the weather was last weekend. And I feel like that was the same for all of my patients this week. Everyone was just in such a good mood because the weekend was so great. Yeah,
well, we got the most amount of listeners, and I know that Dr. Stephen Kent listens to this. He bumped up, so we get an average listener profile, and he bumped up our list by an extra 70 downloads just off two parts of his topic talking about syndesmosis injuries, which is incredible. So if you haven't listened to that, part 2 was out last week, and then the week before was part 1, so definitely go and listen to that. Yeah, it was good. And another thing, this Sunday, so this will be out Monday, I've just looked at my watch and I just got my wrist.
You were looking at it for a while too.
Yeah, I don't have my watch on. But this Sunday, there's still a chance left. I think there's 8 tickets left to the Future Health Network course, which will be an incredible day down in Sydney. And very, very simply, it'll make you a better clinician. I'm just going to leave it as that. It's cheaper for students. It's still pretty cheap as it is. And it'll be a cracking day with good clinicians, researchers, business owners. It'll be good. It'll be really, really good.
I'm excited.
So yeah, Kelly, run me through your running week.
My running week. Okay.
I was just joking. I just could have been listening to the Inside Running podcast a lot. I think it's cool when they're like, 60 minutes,
that's the best part of the whole episode.
And then Monday afternoon, I did 40k at 250s. It's ridiculous, hey?
It's so fast.
Double my mileage in one day.
I was going to say mine's going to be pretty unimpressive because all of my runs are easy at the moment.
Yeah. Now we'll get into a little bit of dialogue, highs and lows, of course. And I wanted to start a new segment, which I didn't tell you about because I knew that it would stew in your mind a little bit. We're going to talk about an Instagram post of the week or some post online that we saw that just isn't the case. And then we
have done that. Haven't we? When we talked about the Lucy Charles Barclay YouTube video.
It hasn't been a segment, but that was just something that annoyed you.
Right.
Or annoyed both of us. But today's topic is going to be everything tendons. Now, we want this to be a resource for students, clinicians, patients, anyone. And you don't have to send your patients to this resource, but I will definitely be sending some of the patients that I see and treat because we say a lot of the same things a lot of the time, multiple times a day. So I thought it would be great to create a resource for people to go and listen to. And if you're someone without a tendinopathy or you're an athlete or a student, you can still listen to this and hopefully get a good understanding of what tendon or tendinopathy is.
Yeah, we're going to try and keep the scientific stuff out of it and keep it pretty easy to digest. But I'm excited. I love tendons.
Yeah, tendons
are my favourite thing to treat,
Tendons are fun
to
treat. Yeah. So, Kelly, highs and lows of the week?
I'll start with my low because it's pretty easy. My low of the week was our washing machine broke on Sunday. Now, if you guys run or train regularly, you will know the pain of how much washing we go through. We do like 5 loads. Well, you don't, but I do.
I'll put the washing away.
That's the deal.
Yeah.
So you've had a pretty easy bloody week then, haven't you?
I have.
We go through we do 5 loads on a weekend. Maybe more, and then throughout the week as well. Everything just goes straight into the wash. So without the washing machine this week, it's been tricky, and it kind of started to get a bit stressful towards the end of the week because I was having to hand wash, and I was like, man, first world problems.
Yeah, and your high?
My high of the week was, as I said, it started off with just being such a great weekend, and just a few of my patients have been achieving some really cool things. I had one of my patients who I know listens to this podcast do a 22-kilometre trail run and came second in his age group, which was awesome. Yeah, that was awesome. Well done, Colin. That was really cool to watch. So Colin's been doing some running programming with myself. So I've been progressing his running program up to to this event for the last 3 months probably. And yeah, he did really well, which is cool to see. And then just some other patients again who one girl has gotten back to playing a lot of tennis after a wrist tendinopathy. Another patient increasing her running steadily each week and feeling really good, and signing up to some half marathons and marathons for next year because she's feeling awesome after a big stint of injuries. So just sort of highs through other people was my high for the week, I'd say.
Yeah, that's
what
great.
What about you?
Makes you love the job, doesn't it?
It does. It
really, really does. Seeing people get back to their meaningful activity, either with manageable pain or no pain, is an incredibly rewarding part of the job.
100%. I agree.
And learning how to do that, I mean, the better you become at that, you've got to go to courses. There's one on this weekend, Future Health Network will make you better at that. So you'll always feel good.
Yeah.
I don't know if that was a good enough plug, but we'll see. See, it was good. So my highs and lows of the week were, the definite high was, it was week 12 at the university this week. So starting their long, maybe short to medium road of their exams. So week 12, they have a couple towards the end of the week, and then for the next kind of 3 to 4 weeks, they have patient exams, final exams, OSCEs, written exams. It's a lot to cram in, and to see they've learned all the information that we taught. And yeah, one of the subjects that I teach, we had our exam for that, and everyone did incredibly well, which made me really, really happy, because sometimes you can be definitely enthusiastic about the information, but you don't always know what's going in. And yeah, it obviously has been, because they did incredibly well. So that was a definite high. Made me feel really good, which is awesome. And it's great to see them now coming to have a break, and a definite well-deserved break for sure. And low of the week, definite this morning. I've been doing a couple of 30k long runs. I went for a run this morning and finished at like 8:30, and I just sat on the lounge until 1 p.m. I didn't even move and napped. I felt sick. I felt so tired. I couldn't believe it. I felt like I was
in the K-hole.
Yeah, I don't even, I hadn't eaten in 5 days, and I was cold and hot. It obviously just destroyed my body.
Even though we ate so much pizza last night.
So many calories. I had 3 gels, the nutrition was fine, and it wasn't even that hard of a run. I did the first 20 with a couple of friends, and then a couple of efforts at marathon pace, maybe 6 kilometers worth, but nowhere near what I would usually do. And yeah, it gave me a little bit of doubt too, because at the 22k mark, I felt so good. I was like, 8k to 30, it'll be sweet. And then I got to 25, 26, and my body was crying.
Sweaty too.
Yeah,
I reckon that's sweaty. I think you just lost all the fluid in your body.
Yeah, I need the salt tablets.
Drenched. I reckon you could have squeezed your t-shirt out. It was so wet.
Oh yeah, that was gross. That was really, really gross. I don't know why I sweat so much. Maybe genetic.
I sweat a lot too, though.
No way.
I do.
No,
I do.
Not
compared to most people.
what a heavy sweater really is.
I think I'm a heavy sweater. I'd call myself a heavy sweater.
Well, I was running with this one lady, Jess, and she's a good, quick runner. And we finished the first 18, and then a couple of people left, and she was like, "Oh, I'll do another couple of K with you as you head off to finish off your last 12." And I was like, "Yeah, great." And she didn't even look like she'd broke a sweat, and I'm just drenched. It was disgusting. I was going to put a picture on the Instagram, but I looked really gross. It was wet, so wet. And then you can't stop and drink heaps of water, because then that makes you feel sick. It
makes you feel even worse when someone comes up to you when you finish saying you look exhausted.
Yeah, I don't know if he listens to this, but Luke Granger from Hunter Podiatry Service, Weapon Podiatry Clinic up around Maitland, Kelly and I having coffee at Blue Dog, he just comes over and pats you on the back and goes, and I turned and said, "Hey," and he goes, "You don't look too good." And I was like, I just had to own it. I was like, I don't feel very good either. Oh, that was horrible. Yeah, I don't know why that happened. Maybe just deep into the marathon block or something. I don't know, but be interesting to see. Also, we're going to put up a poll on the Instagram. I'm going to get a pair of race shoes. That's another kind of high, which I'm excited to do.
Yeah, I get my shoes tomorrow.
Yeah, you've got yours. You got the Speed 3s? No.
Saucony Speed 3s,
yeah. Yeah, that's nice. That's nice.
It was a debacle trying to figure out which shoes to go.
It was. I don't think you should have done that. I mean, I don't know. We talked about it last week. I don't know. I just really love. I think the more abstract the shoe, the better it must be. But I guess if it's based off comfort, and you love the Sauconys anyway.
I like them, and the Vaporflies hurt my feet for 21
that's right.
kilometers.
I always forget that they blister and stuff. Hey?
Blister, but my feet get just too wobbly. I think they can't handle how unstable they are. Yeah.
Yeah, if you run quicker than they're sweet. No, I'm joking.
Well, no, but for like, and it's not a fast run for 42 kilometers. Like, it's not, you're not running fast, so you don't need.
You're trying to run 4:50, aren't you? That's pretty quick.
I think I've backtracked to 5, maybe 5:10.
I don't know why you don't just make a goal that's unreachable like me and just be like everyone else and just say something that you're not even going to get close to.
I've got a realistic goal and an optimistic goal.
Yeah.
My realistic goal, I think, is actually optimistic now.
That's silly. We talked about this, and people will agree with me. I've got no doubt. I don't want to take a black and white stance, but if you have 2 goals, as soon as you have any inkling of not making the first goal, if you don't have the mental capacity, which you're probably not going to for a marathon, you just instantly switch to the second one. So if you're trying to do 3:20, but your optimistic is 3:30, sorry, your realistic one is 3:30, if you're on pace, you're like, nah, I'm not going to push hard. I'm just going to go for the other one. And
I think my goals are more made based off the fact that I've had so many niggles over the last month, though.
Yeah.
Not the fact, like, fitness wise, if I was.
But what happens if you feel good? What happens if you feel good and let's just say argument's sake?
I think I'm stronger mentally than you.
Yeah, but I bet you got 2 goals. But you're going to go back to the second one as soon as it gets hard. Because you're going to be out there for however long, a couple of hours. Do you have that mental capacity for that? After fatigue as well.
We'll see.
We'll see.
We'll see on game day.
Yeah, we'll see. What is your optimistic? What's the numbers?
My optimistic
If you don't mind
goal,
sharing it publicly.
My optimistic goal is between 3:20 and 3:25.
3:20, 3:25. Yep.
And my realistic goal is between 3:30 and 3:40.
Yeah. Okay. Yeah. I still think you should have got maybe like the alpha fly because you're such a smaller person. I think you would just bounce with them.
But I bounce with the Saucony speeds.
Yeah, I guess. I just like I don't know. I mean, it's between. The other thing I didn't even speak to you about was possibly the Adidas Adios 3. Because they've been getting a couple of wins in the marathons lately. And not that you should base your shoe choice off what the winners are.
Did you see that the guys on the Inside Running podcast got to try the new Mizunos?
Oh, I tell you what. And what's her name as well? Michael Nishki. I was talking to him recently and he got a pair of shoes. I'm like, I want shoes. Come on.
Give me shoes.
Yeah, I'm working hard. But in saying that, I posted this thing about the cloud once on the Instagram and he replied and talked about the shoe. And he was saying things about the shoe I didn't even know. So it was kind of like, I do want free shoes, but you're way more deserving because you know a lot more. So it was a bit of to and from. But also, if any any potential anyone is listening to this, I would kill for some shoes. Yeah.
Yeah.
What size are you?
6. Well, 6.5.
Combined with our Instagram plus the podcast, that's like our engagement will be like 3,000 and we can get an affiliate code combined.
What size shoe are you?
12. 11.5, 12 on racing because my foot swells.
I think you need to be a 12 all the time.
No, I'm a 12 in the clouds and they're too big.
Things.
I've got hammer toes.
Yeah, but I think it's because your shoes are too small.
That's right. Our last listener, Dr. Steve McKenna, he said it'll be sweet. He'll fix them. He'll pin them. He'll pin my PIPJs so they're straight. It's fine. They're adapted. Feet are adaptable.
They're
anyway.
Ugly.
They are ugly, but I don't conform to normal standards. I don't care.
But
I probably will get some deformity when I'm older. But we'll talk about that later. Let's talk
about tendons.
Yeah, so I try to think of a catchy topic, and it's going to be the name of the episode, and it's going to be, you've got tendon pain, ? What does it mean, ? Everything tendon management, full stop. So we're going to cover a couple of topics. The broader concepts and I guess topic of tendinopathy, the general consult that we have with patients when we are seeing and treating tendons. What happens when you get a tendinopathy and why? What can we do about it and why? Causes, treatment, recommendations. Cool. So I want to start the whole topic, this is the first one that I want to start with. Everybody can get a tendinopathy. It is not just active people, runners, volleyball players. Everybody can get it.
It's interesting you say that though because it's.
We can't start going off topic already.
Okay.
That's the first sentence. It's actually interesting you brought that up.
I'll bring it up later.
Yeah. So as we said,
it's relevant though.
Yeah, what are you going to say? Are you going to say, say it, if it's just short one-liner.
Okay. Well, Ebony Rio says that so like Achilles tendinopathy, you can get it across inactive and active people, but then there are certain tendinopathies that are quite unlikely to happen in sedentary people. And so, for example, patellar tendinopathy, hamstring tendinopathy, it's quite unusual to see that in a sedentary person.
I'm very disappointed, and I want this to go on record. Everyone listening to this, I know that you haven't read what I wrote down because I mentioned that like 4 lines down. I basically say certain tendinopathies tend to happen in people who do certain sports, e.g. patellar, jumping, running, Achilles.
When you said to me 10 minutes ago, just read through what I wrote down and make sure it's okay.
That's fine. Anyway, so podcast, resource for patients, students, and clinicians. So you want to go from there, and we're going to run through things in a logical order, similar to a consult. Field and answer the common questions we get asked and how we explain them. Now, we're both very, very happy to take as much criticism as possible on how we explain things to patients, because sometimes you can be a little bit siloed, and if you work in a private practice, you can definitely get siloed because you're talking about these things with people that probably share similar values. So if we say anything wrong, out of line, or not evidence-based, or very outdated, please send us a message on the podcast, and we will, I don't know what the word I'm thinking, but we'll acknowledge it and then talk about it on another episode. Mm-hmm. Yeah, so I did want to add as well, like typically we see them, I typically see, and I don't want to speak for you, I see them mostly in the chronic stage. And I've got a couple of theories as to why that is. And I think because tendons, they never really get to the point where they're really debilitating. Like generally earlier on in the tendon, generally speaking, not all the time. I think that because they can be, somewhat of an annoyance pain, and I'm thinking of your Achilles somewhat at the moment as well, when there are 1, 2 out of 3 earlier on, you can kind of push through most of it. And you can kind of, maybe you just miss this run here, or you wear your heel lifts, or you just you don't do what annoys it, and then you can kind of push through and get through, and all of a sudden it's a couple of years later or it's a year later and it's really debilitating and it's affecting your life. What do you think?
I reckon I see them not in like the chronic stage, but not super acute. So I agree. I think people probably let them go for a bit longer than other injuries, like acute low back pain, for example. I think people tend to seek help after maybe like 1 to 2 months of dealing with it and it not going away, because they come in and they're like, I don't know if I need to stop doing what I'm doing or if I need to continue doing what I'm doing, or if I'm on the right, like, it's not getting better or worse, it's just kind of staying the same. Or if people are wanting to increase their load, they're concerned that it's going to get worse if they do that. Then you also get people that come in that with like the chronic
Yeah, I don't see them that acutely, 1 to 2 months. I definitely do, but nowhere near, it's heavily skewed. Like I would think at least 80-20, where it's gotten to that point. And the typical scenario that people will say to us, I find, is the tendon was sore, they rested, so the tendon pain went away, and then they get back into things, and then usually that timeline means it's been 2, 3, 4 months, and then they'll try and get back into things, rest again, try and get back into things, and then they come and see us when it's like, I keep resting and it's not getting better. And that's been happening really a lot lately. So
that's true. Yeah, that's actually a very common presentation, isn't it?
Yeah, we'll talk a little bit as to why that is. And another one that I thought is they just become more, you become so hypersensitive to them as well. Anyway, actually, we'll talk about that after that. So let's talk about a little bit of what we run through generally in a consult and some of the questions that we ask, and we'll, how to diagnose, that kind of thing. But I wanted to mention, and it looks like I'll probably be leading most of this because you haven't read any of it. Actually, well, do you want to talk about those things? Because these are the things that I ask, and I'm sure that you ask them as well. Probably 3 important questions.
Are you pointing to that?
Yeah. Those 3 things right there.
Well, why don't we talk about
You could have added to this if you thought it was out of line.
You lead and I'll have input then.
Right. So we're talking about the subjective history. So someone comes in and you're talking about, or they're telling you what's happened, which, just a quick point, what's that study where people interrupt in the first 11 seconds? I'm horrible for interrupting. and I definitely interrupt you a lot. But
I don't know what the study is, but that's
yeah,
a thing.
like 11 seconds.
I thought it was 13 seconds.
13 seconds. So definitely just when you ask what's going on, you can nearly, like honestly, and I was saying this to the students on Friday, I think you can get a pretty accurate diagnosis without even touching someone. And obviously you will with your testing, but based off the questions and the tissues, you know, they're saying they've had this pain for this long and it warms up and it feels better and then it gets really sore the next day and they don't have night pain and things like that. Like it's unlikely to be a bone injury, for example. Could be, but unlikely. But a couple of questions I will ask: their work or job, what they do for an occupation, what's their meaningful activity, and what's an average week of activity look like for them at the moment, and then prior to the injury, and the injury history and surgery history. And there's obviously more questions that you do ask, but they're really three important ones that I think are the pillars to getting a good understanding of what you're dealing with. What do you think?
Yeah, in terms of diagnostics, I think that's a good starting point for sure. I certainly like to know about the pattern of pain and how it responds to exercise. So does it, warm up with activity or...
Yeah.
Stop interrupting me.
No, but that's in the next one.
Yeah, well, doesn't matter. We're talking about subjective. And that's what they say.
Yeah, go.
I also, and I think I mentioned this a couple of podcasts ago, I always like to ask them what they think is going on. I think that's really important because it helps you to sort of ask those second and third layer questions where if like what their concerns are about it and what they want to be able to do. But that's a question that I'm often keen to know what their thoughts are as well.
Oh yeah, and on that topic, asking about which I know people may ask, what do you do for exercise? Or, what do you do for activity? I find using the word meaningful can sometimes get a different response because some people might walk with their friends, play with their grandkids, look after their kids, 10 hours a week, but for them that's not exercise. But what you want to get from what their activity is, what their work and job is, what loads typically are going through this tendon. So my treatment and my rehab is going to be exponentially different compared to someone is training for a marathon, training for a 5K, they go to the gym, they're a tradesman, they're a nurse, or they just work in an office. It definitely changes what you do, for sure, I think.
Yeah, I agree.
Yeah, and then finding out from their meaningful activity, and this is all fresh in my mind because I was talking about this week with the students, finding out their meaningful activity, what their goal is going to be. So if you're saying, they're saying prior to the injury I used to do this, this and this, and now I can't do that because of the tendon, you know what you need to work back to, or what they would hopefully want to work back to. Yeah. Do you want to riddle this one off, which you just said before?
Yeah, so as I mentioned previously, tendon, as Blake said, it can happen in sedentary populations, but it can also happen in active populations. Certain tendon locations are probably more inclined to be in certain populations though. So Achilles tendinopathy, for example, that can be seen in across the lifespan. So you can, if it's in a younger person, you're probably thinking more so something like severs rather than an Achilles tendinopathy. However, once you're getting into like teens or adults, then we could be thinking of an Achilles tendinopathy. But then again, in the older population, so people who aren't very active but then might start playing with their grandkids, for example, or have some sort of internal factors that are influencing their tendon health, could also develop an Achilles tendinopathy. Then we've got other tendons such as we mentioned before, a patellar tendinopathy or a proximal hamstring tendinopathy, which is quite unlikely to be seen in sedentary populations. If you're suspecting a proximal hamstring tendinopathy in a pretty sedentary person, I'd be probably looking to probably clear the lumbar spine a little bit more closely, if that's sort of the line that you're thinking. Because it is probably something that's more so going to happen in a more active population.
Yeah.
Rather
straight for
than...
CT and then cortisone and PRP through each side of the hip.
Ebony Rio states that patellar tendinopathy can only really happen in jumping athletes, which is I think kind of interesting. She says that the patellar tendon can only be exposed to the load the amount of load that would contribute to a patellar tendinopathy if you are a really strong, fit jumping athlete.
Like end range knee flexion, like you would never get into that position, or not?
No, not end range knee flexion. It's funny as well. Like if you look at, there's a study that looks at patellar tendinopathy in volleyball players or basketball players, I think, and it's actually the stronger, higher jumping athletes that have a higher prevalence of patellar tendinopathy rather than the less strong or the less able jumpers in the teams. So I think that's a lot of where that sort of belief or thought comes from, is that it typically is in really strong, powerful athletes that develop a patellar tendinopathy. I don't know if you can say that it can't happen in other athletes. I'd sort of say it's probably more unlikely to see it in other athletes, but I think it would still be possible to develop a patellar tendinopathy in, I don't know, some other non-jumping sport.
Yeah, definitely. And these cases are very, nothing's black or white. Definitely always in the grey area. It's more likely to happen, in this population, but I'm sure it can happen in all populations.
Yeah.
So, how to diagnose? This is the one. This is the questioning. Someone should be telling you these things. And you can ask these questions in a logical order, and you know straight away, this is tendon. I can smell it. I can feel it. You can't palpate it and diagnose it. Well, you can. That's one of the criteria. But so what are some of the things, and we'll run them off the bat with the first one.
I feel like I'm going to disagree with you with some of this.
You can't, because I'm definitely right.
No, I think I am.
You're going to disagree with some of this?
Yeah, I do.
Okay, let's run through it. So, I'll start off with the first one.
Yeah, this is the one I think I'm going to disagree with.
So, really?
Yeah.
It's funny that you say that, because that one is actually straight from the paper that Ebony Rio and Lorimer Mosley and Jill Cook did. So, it typically has an on-off nature, closely linked to loading, and so we'll just talk about that bit. So on-off nature, closely linked to loading. I agree with that.
I agree with that.
With if you load it, it's typically going to be sore, but if you avoid what aggravates it, it's not going to be sore. And excessive energy storage. So tendons typically don't like fast rates of loading, which is the energy storage, where they shorten and elongate and they store energy and create the spring. They don't like that. That's it. You don't agree with that?
I do agree with that, but I was waiting for you to say the part where with an Achilles tendon, for example, like if they do a slow calf raise, they won't have pain, but if they do a fast calf raise, then they will have pain.
That's what I was... Yeah, that's generally, and when I say generally, not always the case, but it's a typical good it's a good objective test to do to get a clearer diagnosis. You have to agree with that.
Have you seen someone with an Achilles tendinopathy that has pain on a single leg calf raise?
Yes.
So then how are you differentiating that?
With all the other clinical tests. I don't just do the one test, but most of the time they get pain with the faster rates of loading, or as soon as they do something quick. So they might do 10 single leg calf raises and they're like, oh, that's actually sore. Or yeah, around the 5-6 rep, I was getting sorer. And then you make them do something quick and they're like, oh yeah, straight away, right there. And they just point with the finger right on the part of the tendon. Or they hop and they jump and they can't do it.
I do agree. I think you can still have tendon pain through slower movements though.
I don't think I've ever said that, have I?
I think you've done an Instagram video on it.
Yeah. And I said, it's not black or white, it's a grey area. I may have. You don't watch any of my Instagram videos anyway. But
I do watch some.
I may have said that. But if I did say that, I apologise to everyone listening. I will go on the record saying that is not the case. But it can be one of the clear tests to know. Yeah. Especially with Achilles and perineals and tib posts and glutes and things like that. So,
yeah.
Want to go to the next one?
Yeah. So there's a warm-up phenomenon.
I totally disagree. Here you go.
And this is what I think is probably more so drawn out of the subjective history as well, but then you can do your objective testing and it should confirm that too. So the first few, let's just stick to Achilles because it's easy, but the first few calf raises might be more sore and it might warm up and then feel a bit better, or when they walk into your clinic room, they might have a bit of pain with walking, and then you might get them doing some isometrics or some calf raises, and then they walk again, and it might feel better as well. So it certainly has that warm-up phenomenon. If you're going through all of that and it's getting worse, two things that could be underlying would be a really reactive tendinopathy that's just not tolerating anything, and it might need a little bit of calming down. The other thing would be a peritendinitis, which it doesn't typically warm up, and it probably needs a bit more calming down.
Yeah, I find and I will mention this a bit later on, but I find in the chronic cases that the warming up sensation, they say that it warms up, but typically they still have some discomfort. So initially it warmed up and they had no pain and everything was fine, but the more chronic it gets, and again, this is just anecdotal experience, I find that the pain actually never really goes away. So it might warm up from a 5 to a 1 or a 2, but they're like, yeah, I can still feel it, but it's manageable. And then when I stop, it comes back the next day and so forth. And then weeks and months later, they're like, it just got worse and worse to the point where it never warmed up and I just couldn't do it.
Yeah.
Yeah. Next one. This is a really, really easy one.
Yeah. Again, sometimes grey though, I think. So pointing to an area of the tendon.
You don't think that's right?
Yeah, I do.
I'm not going to point to their brain.
No, well, think about a proximal hamstring tendinopathy and our conversation with Nikki when we were talking about proximal hamstring tendons. Sometimes it's not a pointing to it with one finger. Sometimes there can be a diffuse location in certain areas. And sometimes with a glute tendon too, like it can be a little bit vague, and that might be because there might be some sort of bursa that's also part of the picture as well. They can sometimes go hand in hand together, and it doesn't mean that it's not a tendon, but it might just be a tendon and something else. I agree though, for an Achilles or a patella tendon, then yes, they're typically going to point to it with one finger, and it's going to be a localized point of pain.
Yeah, sweet. And yeah, so if they're pointing on top of their knee or their midfoot or underneath their heel, probably unlikely that it's a tendon.
I'm just being real for everyone as well.
Yeah,
there's
but you
nothing
know,
worse than learning rules.
Yeah, no, but I definitely didn't say that if it doesn't match every single thing that I say, it's not a tendon.
Okay, what I'm just trying to get across is if there's students or younger clinicians listening to this,
there are.
I don't want them to think that it has to be that one thing. I want to make it very clear that it can sometimes go in a different direction, but you're still managing what we're talking about.
Have we not said that? Or do we have to say it every time?
I'm just saying.
All right, okay. And we'll make sure we say that after every point. But no, you are right. Kelly is completely right. Yeah, it's always in the grey area. So let's talk about you did that one, so I'll do this one. Pain is rarely experienced at rest or during low load tendon activities. So for an example, a person with patella tendinopathy will describe a jumping, movement to be painful, whereas cycling might not be painful. So the provocative loads that are going to stress that tendon typically will give that discomfort. However, it's not always black and white, and it might actually be the other way around.
What I was going to say is, what about a proximal hamstring tendinopathy and someone's sitting? They're getting pain at rest.
Yeah, definitely.
But they're not experiencing a loading. There's not an excessive fast movement.
That's why I said pain is rarely. I didn't say pain is always experienced with high loads and not the other one.
Okay.
You can do the next one with all this writing. Yeah.
This is because of your run this morning.
I feel like that guy. Who's the guy from the Inside Running that does? It's not Moose. It's Brady. Is it? He does all the show notes and stuff like that. And I'm sure this is how he feels sometimes. The other people just rock up. He's spent hours and hours going through this thinking, what's going to be best for these lovely listeners? And then you just tear me down to shreds. But yeah, you're right. What about this one? I added this one in right at the end. What do you think? Stretching is usually okay, but sometimes it isn't. But it also is.
I would say it depends on the location. So an insertional Achilles tendinopathy usually doesn't like compressive load, which would be a calf stretch or, going up a hill. Well, I guess that's more excessive or higher loads. But I think an Achilles tendinopathy, and even my tendinopathy that I have at the moment, which is more mid-portion, dorsiflexion's the thing that it hates most.
But not always. Not for everyone.
No, not for everyone.
No, but also for some, but not everyone.
Yeah.
Yeah. Anything else where it's in the middle? But yeah, the stretching part, some people, and that's why
I think stretching's been sort of demonized a little bit in tendon
Well, our
management.
first episode, we attacked it. Well, we didn't really attack it, but we said that it's pretty shitty if people are wasting their time when they could be doing other more high-value treatment.
Exactly. I don't think stretching needs to be a hard no, like a lot of people say. I think it's an aggravating... Well, I think... probably. It's probably something that doesn't need to be done. Well, I don't think it needs to be done for tendons.
But it could be in some cases.
Now you're just being confusing.
No, I'll drop it now. So let's quickly recap of what we've said.
Wait, I wasn't done talking about stretching. I have definitely had some patients that find stretching and in small doses to be helpful. I would say someone that's got an aggravated tendon, I would probably tell them to draw back on the stretching because I think it's a load that their tendon might not like. But I just don't think it needs to be a hard no like it is sort of thought to be. But I also think it's kind of wasting your time at the same time.
Yeah. So to recap, generally speaking, an on-off nature that's closely linked to loading, and the more that you load the tendon with the provocative loads, generally the more painful it will be, and it's related to energy storage. So tendons typically don't like fast movements. People will sometimes report that it warms up and gets better and feels really good, and then the pain may come back, after, maybe even towards the end of the activity or even the next day. And typically the more chronic cases, the pain may never warm up completely, but may feel better. They'll definitely point to an area of the tendon in most cases, but again, that can be a pretty generalized area, but they're not going to point to on top of their knee or the top of their midfoot. Also, pain rarely experienced at rest. It's usually when you're doing the provocative loads, and knowing what loads are going to aggravate a tendon will make sense. So using a patella tendon, for example, or an Achilles even for an example, an Achilles tendon probably not going to be sore with swimming, but it's probably going to be sore with running.
Yeah.
Now, the last one I've saved for the end because it's probably the most important, I think, and it's one of the ways to get a really good understanding. Tendons talk to us the next day or even that afternoon if you train in the morning. So I will always ask someone how it feels during, how it feels after, and the day after. And then from a recovery, improvement standpoint, when I'm seeing them weeks later, I'm seeing if that's improved. So if they're saying, I don't actually wake up that stiff in the morning, it's still painful, but it's better.
Interesting.
Because I find that that's good for them to understand. And I also want them to know that it's a really good metric to know they've done too much. Like if you go for a 30k run and it really sore the next morning, you've probably done too much. But if you go for a 15k run and it's actually manageable, you've probably done just the right amount.
Yeah, I think tendons definitely like to talk to us the next day, and I will like to keep that level of discomfort low and stable. I probably say something a little bit different to my patients though, and again, I think that this is
something different. Are you serious?
I say something different in that, again, this is anecdotal experience. This isn't something that I've read or based off any articles that I know of, but I actually find that pain the next day or pain in the morning is one of the last things to get better. And I often make that quite clear to patients. I say, look, we want to keep that pain the next day low and stable. We don't want you to be having, significant debilitating pain where you're completely hobbling, but having some discomfort first thing in the morning for that first sort of 30 minutes until you get moving. I think that sticks around for a while. And I don't think that's a measure for me of progress.
Definitely one of the measures, if it's not as painful. One of many. So that's one I'll get them to think about. I do agree. And you should, very rarely do you wake up with no pain, but I definitely think if they're feeling better when they get out of bed in the morning, that can be one of the metrics you can use to get them to think about if it's improving. Do you use it to know if people have done too much?
Yeah, I do. I'm probably thinking about someone who has low and stable symptoms, and they're talking to me and saying, oh, I've still, like, it's fine during the day, it's fine with activity, it's just this pain that I'm getting first thing in the morning that's the worst. I often say, well, I genuinely think that that's the last thing to improve. I do think that sticks around for.
You did say low and
while.
stable. That's a good thing to say, because like you said, it's pretty normal, and definitely for us, because we understand tendons very well, because it goes in our university degree and we do a lot of study on it. For people that are seeing us who don't have a great understanding of tendons, that can be a little bit of a deterrent, because you may give them some rehab or program a run or an activity, and they may wake up extremely painful the next morning. And if you haven't told them that tendons talk to us the next day, they can think that they're back at square one. So you've definitely got to explain how important it is to have a good understanding of your tendon, really.
And if you do wake up and it is significantly sore, it's not something to freak out about. It is your tendon saying that you have overdone it, but it's not your tendon getting worse from a pathological point of view. It's reactive and it's hurting, absolutely. However, it's nothing to be concerned about or something that you need to sort of backtrack and have a huge amount of rest for. Often a couple of days, getting back on track again, and then you should be okay to keep going.
Yep. And that tendon pain may not always be related to the load, which we'll talk about in what can cause tendinopathy. You may have slept badly, or you may have had a huge day at work. You may not even done the activity the day before, and sometimes it can still be sore for factors we just don't know anything about. So that's pretty normal. I like to say, and I've been toying with this a little bit lately from an analogy, and it makes a lot of sense. We want those periods where it is really sore, that's going to happen. That's probably a guarantee with us getting this tendon better. But as long as those times where it is flaring up, it's becoming less consistent, that's another measure that we can use that you're improving, where it might be only happening twice a week rather than 5 days a week. What do you think of that one?
Yeah, I think that's really good point. Yeah.
Cool. So a couple of those metrics, pretty easy to use to diagnose. And someone's saying it to it, you got a tendon on your hands. Get the knife out, and not the knife, what do they call it? The scraper, and start frictioning that bad boy. So now that's
sarcasm for those of you who don't know Blake very well.
Now we're up to, I'm just going to date and note this time. So this is where I will hope our patients will listen from. So welcome to the Sports Medicine Project if you're a patient of ours. We're going to talk about a couple of different topics, which I'm sure we would have talked about in the clinic. And the two questions, what happens when you get a tendinopathy and why, and what we can do about it. Do you want to start us off, or you want me to start us off?
You start and then I'll butt in.
Yeah, great. So before we talk too much about it, I wanted to start with this line. Pain generally is there to protect us. That's why we get discomfort and generally why we get pain. So if I imagine you're in front of a hot stove and the stove is really hot, you put your hand on there and you burn yourself, you definitely want that pain, so you take your hand away or you're going to lose your hand. Once you turn the stove off, and I know that the stove is off, even if you say, can you put your hand on there again, I'm probably going to have some hesitancy. And if I continue to do that over time, I may even get the sensation of the hot stove. So pain can be a little bit funny in that case, and that can sometimes happen with tendons in a similar route. What do you think?
I've tweaked that as recently, and I have sort of changed it to it's your... And this is probably less relevant when we're talking about tendons, I suppose, but it's your body thinking that it still needs to try and protect you.
Nice. That's way better than what I said.
Because it's not... I've gotten myself stuck a couple of times saying it's your body thinking it needs to... Or it's your body trying to protect you in the person thinking that there's a good reason why it's painful and trying to protect you. However, often it's your body, more so thinking that it still needs to protect you when there may not be a pathological reason necessarily for that.
Yeah, and that leads us... Yeah, it does. It's really good. And that leads us into our first point. You definitely can get and are likely to get pain with movements and activities that don't generally give you pain. So you may have been able to do running, volleyball, basketball, soccer without any pain or discomfort, or sprinting without any pain or discomfort, and you may do that same amount of load or even less and have that pain and discomfort. And sometimes, as you were saying, that can be from that protective mechanism. Would you add anything to that?
I think there can still be changes within the tendon to validate that as well.
Yep.
And that's based off some research that I've read. You can't. They say that you can't have a tendinopathy without changes to the tendon. Like if you've got tendon pain but you don't have any changes to the tendon on the image, then it's not a tendinopathy. I'm not sure how I feel about that.
Yeah.
But
yeah, okay.
I think that there's some chemically driven component to it as well, often.
Yeah. So on that topic, talking about tendon change, regardless of really how much it changes, tendon change doesn't always relate to how much pain or pathology there is. So basically, pain does not equal tissue damage.
Yeah. So if you're a patient and your GP or specialist or someone has sent you for an image and you have an Achilles tendinopathy or Achilles tendonitis as picked up on your ultrasound or MRI, that doesn't necessarily dictate the severity of what your symptoms are going to be like. So we know that non-symptomatic, so people that don't have pain, could still have a tendinopathy if we were to image them.
Based purely just off the image.
Just purely based off the image.
Yeah.
So we know that pain, as Blake said, pain doesn't always correlate with what the tissue looks like. So that gives us a really good opportunity to still get on top of it with some good rehab, despite the fact that your tendon may not look the prettiest on a scan.
Yeah, and knowing even if it does look not the prettiest and there is degenerative change within the tissue, we know wholeheartedly from the research and from seeing and treating it so often that pathological tendon, in quotation marks, still has the same capacity to be strong and resilient as a normal healthy tendon without any change.
Yeah, I agree. Something that I did want to mention, and we should have mentioned this earlier, but we didn't, is that I don't think that we need to get images done for tendon pain. It's often a clinical diagnosis, and an image is not going to really change anything unless we're considering that there might be something else going on. So you may use an image to sort of rule in or out this injury. You were going to say something then? I
was going to say, unless, and this is only from a foot and ankle standpoint, unless you're maybe suspecting like a longitudinal tear or something a little bit more severe, because you're just usually generally a little bit more aggressive with the offloading and your rehab, which you can get from the clinical symptoms as well.
Yeah.
So what the other thing that we get asked as well, when you do have that change to the tendon, it's very likely that tendon will look thicker compared to the other tendon or any tendon really. So that actually, and I remember you actually telling me this, I hope it's still correct, that doesn't really mean anything. The tendons still have the same amount of capacity to get stronger. And if anything, is some silver lining, that thicker tendon is at a lower risk of rupturing. Is that right? Do you remember telling me that? Well, that's changed.
Yeah, I'm not too sure about that one. I probably can't comment on it. The reason that it gets thicker, and I actually jot this down just at the end in case it came up, but the cells that are within your tendon, they're called tenocytes. So they're the cells that get stressed with load, and that could be internal or external loads. They produce these other cells that actually attract water into the tendon. So that's what causes it to thicken and swell, because tendons don't usually have a high water content. They're very collagen based. So the changes within the cells in the tendons actually what draws that water there to create that thickness. And that then, I mean, if we're continuing on with what actually happens with a tendinopathy, that actually triggers a repair process. So that's when you're getting this stressed tendon, and then it's trying to repair itself because there's tendon changes, and that's what can cause, well, initially that reactive tendon, but then you can go on to that state of degeneration or disrepair or tendon degeneration, which isn't great words to hear, but more often than not, it's nothing nasty.
Yeah, and why they can be sore as well is they typically follow a pattern where you avoid the movement that's aggravating, and then when you go to get back into the movement, it's sore. So it's almost like, and I always use the analogy, if I didn't lift my hand above my shoulder for 4 weeks and then I went to do it again, I probably don't have any pathology in my shoulder, but it just feels stiff and sore and a little bit odd. And that's what can happen with tendons. You avoid what makes it sore. So when you start doing it again, it can be almost like doing it for the first time. Yes, you can build back quicker, but that can be one of the reasons why you can get some pain and discomfort doing things that weren't typically sore.
Yeah, something that you will hear me say quite often is that tendons don't really like rest. You can rest a tendon and it might feel better for the period of time that you're resting, but then as soon as you go to do something again, you're probably going to feel it. Tendons really like and they really need progressive loading, and that's why rehab is so important, and that's why it's important to maybe not avoid the activity that's causing it pain. We want to try and keep that capacity and that load tolerance high if possible.
Yeah, and you also, when you get a tendinopathy, you do get a reduction, and again, we're not able to say how much, but you do get a reduction in capacity, but you're usually able to keep some function, and that may be for a short, medium, or long term, but the goal is always to increase that capacity. And when we say capacity, we just mean how much the tendon can tolerate. So that does happen, unfortunately. So it doesn't mean to stop everything completely. It just means you've got to find where's the right amount where you're still doing something, but you're not doing too much. Justin Smith, he likes to say, we want to do enough to wake it up without flaring it up. So, Kelly, what can we do about it, and why do we want to do anything about it?
There's lots of things that we can do about it. I really love treating tendons, as I've said before, because it's a long rehab process and they are slow to start to get better, but you can always be doing something. So it's not a type of injury where you've, as we said before, where you've got to rest and completely shut the doors. There's lots of things that you can do for it. The first thing that we really want to do to start that process is find what your level of tolerance is. So how much can we stimulate or sort of trigger that tendon, but keeping your symptoms low and stable, or keeping it as a happy tendon, not a completely aggravated tendon. Yep. That's the first thing that we want to do. I'll often say to patients is that, if we're not flaring it up or at one point or another, then we're probably not testing it enough or pushing it enough. I think flare-ups are common with tendon pain, and it's a bit of a to and fro, like us working together, troubleshooting together, going back and forth together about finding what that starting capacity is for you. Yeah.
So the load and making the capacity stronger is the most important. The really basic, simple principle is that tendons need load or a stimulus. They then recover, which they need time to do, and then they adapt, and then they're stronger for then whatever load you are going to place on them. So that just takes time, but that's generally the concept to think about. So that load needs to be challenging, and like Kelly said, it's very likely you will have times where there's flare-ups or it's sore, or you may have done too much. As long as I think that would be probably a better scenario that you've done too much and you do get a flare-up, because we know that this is your new ceiling, rather than you haven't done enough and you're kind of winging it and getting through it without it being painful. So some pain as well is okay, and almost encouraged. There was a good study that came out that looked at pushing into pain with tendon rehab and found that people had reported less pain and better function and improved strength markers when they pushed into pain that was between a 1 and 3 out of 10 compared to no pain with the rehab. So that's pretty normal. And I get really upset when people are told that they shouldn't they shouldn't be doing things unless they have no pain. It's just not the case.
No.
You need some discomfort. And tendons you do. Bones and things are different. Tendons you do. Definitely. Yeah. So you can also get back to a level of load you want to pretty quickly. Probably shouldn't say quickly, but you definitely can get back to what you want to do. But it's more likely you'll get back to that when it's manageable pain rather than getting back to with no pain. Great. Anything to add into that?
No, I think we'll get into the specifics when we talk about treatment.
Yeah. So right off the bat, load's got to be challenging. Find what's meaningful. Aim to get to that with manageable pain, and then to pain or then to pain-free. Make it strong. Generally speaking, find what's tolerated. Look at the 3 general markers, strength, endurance, and stiffness, and unload it if you can while you're doing the rehab. And I think it's safe for an Achilles with heel lifts or with a peroneal with a laterally wedged orthotic device. Yeah. What do you want to talk about those?
What is that talking about? Just treatment all over? Or?
Yeah, treatment.
Yeah.
And broader concepts of treatment.
I mean, as we spoke about previously, the fast explosive stuff is often the more challenging load for tendons. So initially what we might do is expose that tendon to challenging loads that are slower or not even moving. So isometric holds perhaps, where you're just holding a heavy weight in a position that is loading that specific tendon. So maybe like a single leg calf raise or what are they called? A Spanish squat isometric for a patellar tendinopathy, or a long lever bridge isometric for a hamstring tendinopathy, for example. Because we want to be giving it that stimulus to be able to adapt and then get stronger. If I think at that point in time, regardless of how irritable that person's tendon is, we can start to incorporate some sort of faster loading rate. So even if it is open chain, for example. So for clinicians, you'll know what that means. For patients, that might mean like instead of doing a hop on the spot, you might just really quickly be pointing your toe forwards and backwards to get your tendon used to some sort of faster loading rates. Later down the track, that can be progressed into things like hopping and jumping, which is typically going to be a higher tendon load and more challenging for the tendon. If a person's able to tolerate that earlier on, then keep going, happy days. But if not, then that's some of the things that we might be changing or modifying to get you towards those meaningful activities. Yeah,
sweet. Awesome. I don't have anything to add. That was really good. So also setting realistic expectations, and this is moving on to the recommendations. You've got to set realistic expectations, and you've got to repeat that constantly over the consults, because having a high health literacy, people are very commonly coming to see us with, great understandings about many things, but very likely not a great understanding of tendon, and that's our job to help educate and increase their health literacy and self-efficacy. So you've got to repeat how tendons behave, what we expect to see with the rehab, what we need to see with the rehab, and why, because the better they understand it, usually the more compliant they are. They'll probably come back to see you even though they've had a flare-up, and generally the quicker you get back to their goal and they get back to their meaningful activity.
Yeah, I think expectations is so important because they are slow injuries. They do take a long time to get better and to make some progress. So making sure that you've said that from the start. If someone's come in with a chronic tendon problem, I have no problems telling them that it's going to take 12 to 18 months to start to get it feeling a little bit better. And that doesn't mean 12 to 18 months of doing nothing. That's 12 to 18 months of doing hard work and a lot of that meaningful activity that you want to do. But don't be surprised if your tendon's still, sitting there in the background bothering you a little bit. If it is more of an acute tendon problem, then I still have no problems telling them it's going to be 3 to 6 months.
Yeah, and if you're listening, that's not 3 to 6 months or 18 months of seeing physio every week or seeing physio, every couple of weeks. There will, and a good...
Unless they want to.
Unless they want to. You think you want to see physio every week for 18 months? I guess so, if that is the case. If they want to, they can definitely do that. I don't know how much value there would be. Well, I guess there would be. But anyway...
If you were coming to see me every week, it would be in the gym doing active rehab stuff. I wouldn't be putting needles in anyone. Yeah, and if you've been told you have a tendinopathy and you're being told you need to go back weekly, twice a week for adjustments or dry needling and massage and things like that, of course there are cases where if it makes you feel better and you can do more rehab with that therapy, there probably could be an argument, but that's not something that's going to change the tissue, and it's probably not very sustainable, and I would question why that needs to be. I don't have a valid answer. I guess you make the decision, but I think that's a good point.
Thanks for listening, everybody. Any questions, go over to our Instagram, shoot them through. We're going to do a couple of different segments as well when we get a couple more listener questions for next week's episode. Sounds good? Awesome, guys. Have a good week.